The approval of Lorlatinib, in terms of how that shifts thing, is still unclear, and I think that was part of the point of the presentation. Unclear not because of the lack of efficacy, unclear because the data just aren't consolidated enough in sequence in terms of trial data showing that going from one to another is better than going to a different thing. We're not there yet, and what I think this does is gives us a new tool to be able to use. And I think as long as, again, there's a rational approach to this based on how the patient's doing and what the molecular biology is with additional testing, I think going forward with it is certainly reasonable in the post-alectinib setting. But other things should be considered also, and can be considered, fortunately. Those things would be other ALK inhibitors, particularly if the mutation-specific data tells you that you should not do Lorlatinib, for example. And the other would be chemotherapy. As I had presented in the conference, chemo still is a very good option for these patients and should definitely be considered as something, particularly if we need something reliable to get patients over the symptoms they're having.